I'll be talking about a vaccine update for immunocompromised hosts. I wanted to focus on specific strategies and differences in recommendations for immunocompromised hosts from the general population. Okay, thank you.
He was just opening the battery tray and closing it.
Great. I don't have any disclosures. And we'll be going through some background, general principles of vaccinating immunocompromised hosts, and some vaccine-specific considerations, and then COVID-19 vaccines. So some general principles about immunization in immunocompromised hosts. What is actually an immunocompromised host? We'll talk about how there's often not a lot of data in vaccines at the time of there are larger clinical trials because they want healthy volunteers that are going to have good immune responses. They don't want it enriched for people who are not going to have robust immune responses or going to have the infection that they're looking to prevent and making their outcome numbers look worse. So what is an immunocompromised host? So anybody with an altered immune competence, and that can be just from immunosuppression, that's something that we're doing to them, something iatrogenic, an immunodeficiency, such as like a genetic immunodeficiency. I just saw somebody with hyper-IgE syndrome, for instance, or generalized immunocompromised states. It can be primary, meaning that it's inherent, or acquired secondary, like iatrogenic ones. And they obviously, anytime you have an altered immunity, it can affect not only the efficacy of the vaccine, how well they work, but also the potential safety of vaccines, particularly when we're talking about live vaccines. So this is just in general when we look at vaccine development, what happens. Obviously there have been examples of accelerated development that we've seen recently, but there's basic science research, preclinical trials, clinical trials, FDA review, ACIP, the Advisory Committee for Immunization Practices, which is part of the CDC. And then there's the phase 4 post-marketing data, post-approval data, where we get more information. Some of the vaccines that we see, particularly in relation to COVID, are not necessarily been approved. Up until, well, the Pfizer and the Moderna have been approved, but not the new Omicron booster. It is authorized for emergency use, so there's that other category that can be in place as well. Here is the current table of all the vaccines, and you can see at the top, this is a really nice table because it looks at kind of different categories. Pregnancy is a relatively immunocompromised state, and that's why it's often put in this category. And then you can see other immunocompromised, and then HIV in particular, because there's a call out in HIV depending on your CD4 count. So not everyone with HIV has a significantly altered immunity. Patients who are well controlled on antiretroviral therapy, for instance, there's not necessarily a contraindication to some of the vaccines. And then end-stage renal disease, there are some specific recommendations around that. And then you can see some other things that are not necessarily immunocompromising conditions, but maybe conditions that confer a higher risk of some diseases. So we know that immunocompromised hosts can have an increased incidence of vaccine-preventable disease. When we think of things like even pneumococcal disease and other diseases. But as I mentioned, they're often excluded from the initial studies that led to approval by the FDA, so we just don't know. And sometimes there's just like a blank box in terms of recommendation. We saw that for a long time with HIV actually, and zoster vaccine, where there just really wasn't a recommendation. So people didn't know what to do in the absence of a recommendation, sort of had their own practice, because there wasn't data to guide what to do. So, for instance, as I mentioned, with HIV, the incidence of herpes zoster is actually much higher, even when people are younger, so younger than 50, which is our current indication. Incident herpes zoster is actually higher, and it actually doesn't even matter what their CD4 count is in these patients. Their incidence is higher regardless. And we know the efficacy of the recombinant zoster vaccine is actually quite high, in the high 90%, but this was all in non-immunocompromised patients. And this was the ZOE trial, which led to its FDA approval of Shingrix. But now we have data, years later, that look at its efficacy and safety in immunocompromised individuals. So this was a very large study with thousands of individuals who had undergone a stem cell transplant, and looking at incident herpes zoster infections in patients who received the recombinant vaccine versus placebo. And you can see here the cumulative incidence, that graph, the line for the people who got recombinant zoster vaccine was actually much lower than placebo. So it worked, and it was safe. There was not a harm signal in this vaccine for patients who had undergone transplant, which they're on heavy immunosuppression. So not all immunosuppression is the same immunosuppression. There's categories, I look at it as high level and low level. And oftentimes in low level immunosuppression, I'm not treating them any differently than immunocompetent hosts. So what is high level immunosuppression? So anybody with a combined primary immunodeficiency disorder, that's CVID, those kinds of diseases confer that's a higher level of immunosuppression. Anybody receiving chemotherapy, much of the chemotherapy is immunosuppressive. Soon after a solid organ transplant, as I already mentioned, people with HIV with a CD4 count less than 200. And I think when we're thinking about what we do, steroid therapy, not all patients with steroid therapy, but if you're greater than 20 milligrams of prednisone or equivalent for more than 2 weeks, I consider that high level immunosuppression. And those are the type of patients that we would think about doing PJP prophylaxis as well, because there are increased risk for that too. Certain biologic immune modulators, or rituximab, not all biologics confer the same level of immunosuppression. And then of course, stem cell transplant, and the degree of immunosuppression is really variable depending how long ago they had it and whether they have GVHD, for instance, because if you have GVHD, graft versus host, then they're going to be on higher dose steroids and higher immunosuppression. So this is actually a study this was actually from the CDC data, but they looked at antibody responses in patients after 2 mRNA vaccines for COVID based on immunocompromising conditions. And what you can see here is the percent with an antibody response. We know that antibody response may not directly correlate with incident disease, but this is a surrogate marker. And what you can see is that patients who are receiving chemotherapy, for instance, they have a variable rate of response. Potentially the darker blue ones, which are hematologic cancers, have a lower antibody response rates. Patients on hemodialysis actually did okay. So even though that's a relatively immunocompromising condition, patients seem to respond to the 2 mRNA COVID vaccines. But as you can see, organ transplant patients, they cluster on the lower side in terms of antibody response. And this actually led to some changes in the recommendations after this data about what we consider as the primary series in someone who's immunosuppressed. 2 doses aren't sufficient in that organ transplant group, so actually the highly immunosuppressed patients should get 3 doses instead as their primary series. And then immunosuppressive therapies, it really depends, it's a variable group. The other thing that we have to consider in patients who are immunocompromised is timing of vaccines. So if we give somebody a vaccine who's just had an organ transplant, it may not be the best time for them to mount a response. But we also want them to be protected. So how do we weigh that? The benefits of early versus delayed. And ideally what we want to do is try to get them vaccinated before they get immunosuppressed so they have that response before they go into a transplant, for instance. In solid organ transplant recipients, the guidelines are for everybody to review their vaccination status and make sure that they're appropriately covered. At least 4 weeks prior to transplantation for live vaccine, so that there's not any concern for disease related to the live vaccine. And then at least 2 weeks prior for inactivated vaccines to allow them to create that immune response, so going into transplant, they'll be protected. Post-transplant timing of vaccines, they like to wait at least 3 months. And again, it's because there's a heavy amount of immunosuppression that's iatrogenic right after the transplant. So if we give it, we probably are not going to get a robust response. In terms of stem cell transplant patients, we look at pre-transplant timing, post-transplant timing, and also we have to take into consideration the donor. So again, just like with solid organ transplant patients, we review the vaccination record and we want to make sure that they have had their vaccines pre-transplant if possible. And this is a good example of measles. We really want to make sure that patients are vaccinated against measles because there have been outbreaks, although post-COVID era or COVID era, we've actually seen far less measles than we did in the pre-COVID era. No live vaccine within 4 weeks of conditioning. Again, conditioning is heavy immunosuppression, so we don't want that risk of getting vaccine-related illness, although quite rare. And no inactivated vaccines within 2 weeks of conditioning. And then, aside from influenza vaccine, which can be given as early as 1 month after transplant, we generally wait 3 months. And again, the COVID vaccine considerations are also pertinent because the timing is really important, but ideally 3 months at least post-transplant to allow the patients to have a more robust immune response post-transplant. Donor, no specific recommendations, although there is some caution if a patient has just gotten a live vaccine. Then there's some other strategies that we look at that are specifically for patients who are immunocompromised and whether apart from the standard recommendations for patients. So there's adjuvanted vaccines, and I'll talk about examples of that. An adjuvanted vaccine is essentially a vaccine that has an immunologic booster in it. So something that is not the vaccine itself, but something that we know stimulates immune response to get more out of your vaccine. And that's often given in inactivated vaccines, which tend to not be as potent in creating their immune response. So, so a good example of this is actually Heplisave. So Heplisave is a Hep B vaccine. It's a recombinant adjuvanted vaccine, and the adjuvant is a novel adjuvant, a TLR9 agonist. Toll-like receptor 9 is one of our parts of our primitive immune system, toll-like receptors are, that recognize non-self and distinguish it from self. And they recognize it through something called PAMs, or pathogen-associated molecular patterns. And TLR9 is specific for identifying patterns that are in viruses. And so basically, when we give it with an agonist, it revs up that part of the immune system to create a more robust response against that recombinant Hep B vaccine. We actually know that it's quite effective when compared with our standard Hep B vaccines, and it's only 2 doses, 1 month apart, which creates a good immune response. Another example of an adjuvanted vaccine is the recombinant herpes zoster vaccine, which has replaced the live vaccine and is actually even more effective than the live vaccine, which is no longer available. And it actually uses this interesting extract from a tree native to Chile that is actually one of the most potent adjuvants, and which is why We can probably blame it for a lot of the site reactions that we get with patients, that patients get when they have this vaccine, because the majority of people will have some local site reactions to the Shingrix. One thing that we do know about adjuvanted vaccines is they can also, because of this immune stimulatory benefit when it comes to creating immune responses against vaccine, it can actually be deleterious to patients who are immunosuppressed for the reason of their transplants, because it can lead to maybe even rejection or immune responses against the transplant. So revving up the immune system in a way that we don't want it to be revved up. So that is a concern, which is why some transplant docs are a little bit wary of using adjuvanted vaccines, particularly early on after transplant. There's also high-dose vaccine strategies. So just this season, we've seen a more robust recommendation from ACIP after years of a wishy-washy kind of recommendation for individuals 65 and over to actually preferentially get the high-dose flu vaccine after years of being, it's the same, you can do either way. But this year they put their foot down and said, yes, you should do the high dose for 65 and over. And this is really based on this study, as well as some other smaller studies that showed a 24% relative decrease in incidence of laboratory confirmed influenza in individuals 65 and over who got the high dose vaccine. So some strategies for patients who may not mount a good immune response, whether that's to aging and senescent immune responses versus being immunosuppressed, is to do a high-dose vaccine strategy. Just give them more antigen, then they'll make a better response. There's also additional dosing strategies, and this has been used. One example is COVID vaccination, to do a 3-dose series for a primary vaccination rather than a 2-dose mRNA series. But this has also been in the case of hepatitis B vaccine, where you can just give an extra 4th dose, which has led to more significant immune responses with Hep B seropositivity. So this is one of the studies, 4 doses of vaccine compared to just the standard 3-dose vaccine. And there actually even had an intradermal arm. So in the last talk, I talked about how intradermal can actually be have very good immune responses, and this study actually looked at a 4-dose intradermal vaccine as well for Hep B. And this was not with the TLR9 agonist vaccine Heplisav. This was with the standard 3-dose series Engerix or Recomba X. What about the use of live vaccines? So measles vaccine is one that we definitely want people to be protected. We know that there are pockets of communities that are relatively vulnerable to measles outbreaks. We've seen measles outbreaks in a number of places. We saw one in Disneyland in 2015. That spread to hundreds of cases throughout the nation as that focus was over the holidays in Disneyland and Disney World, and had numerous people attending from different states and then spread. But we've also seen it in immigrant communities in the Midwest. So we know the potential is there for significant outbreaks. But because it is a live vaccine, we do have to be cautious in patients who are immunosuppressed. But it doesn't mean they can't get it ever. So for patients who've had a transplant, we recommend it's at least 2 years after a transplant that they don't have any active graft versus host disease, which would be, they would likely be on immunosuppression, higher dose immunosuppression for that, and at least 1 year off of immunosuppressive medications, and 2-dose series should be given. We basically treat them like they've never gotten a measles vaccine, because often with the conditioning, they actually lose all their prior immune repertoire, and so we want to just restart giving them immunity to measles. And this is in terms of probability of being seropositive to measles. With previous vaccine, after their transplant, they actually lose it quite quickly. There is a concern for vaccine-derived disease, but much less so if they're off immunosuppression. And with measles, it's quite rare, and so we don't really get too concerned if they're not in that heavily immunosuppressed window. Here is a case that was vaccine-associated measles in the stem cell transplant that was published, though, so it's not impossible. An expanded age recommendation. So I'll talk about this as a strategy for immunocompromised hosts. So some diseases, like I mentioned, shingles, can be they don't wait until you're 50 to get, there can be a risk even when you're 18 and over. And so for immunocompromised hosts, the recommendations changed in 2021 to actually give it for everyone 18 and over. So 2 doses for all immunocompromised hosts 18 and over, not just HIV, but the stem cell transplant, solid organ transplant. PCV20, this is another one. Now we know that PCV20 has replaced PCV13 as the preferred, but also PCV15. I'll talk about a little bit why it's both PCV20 and PCV15. But essentially, for all individuals 65 or greater, but if you are at increased risk for invasive pneumococcal disease, you can get it at age 18 and over. The reason it says 19 and over is simply because there's pediatric guidelines that go up to 18, and then there's adult guidelines that go 19 and over. So ACIP will say 19 and over in the adult, but it's actually licensed and approved for 18 and over, just so that that little bit of confusion there about why there's a discrepancy in the ages. But it's not just immunocompromised folks like asplenic folks or functionally asplenic folks or people with HIV or other immunocompromising conditions. The list of individuals at risk for invasive pneumococcal disease is actually quite large, and many of the patients who we care for with chronic liver disease, chronic lung disease, chronic heart disease, smokers. So it's many people that we see that we should be considering for pneumococcal vaccination before the age of 65. In terms of the PCV20 versus PCV15, the ACIP did not endorse one over the other, and you may think, wouldn't you want to get the 20 because it's more? Yes, but there are some operational issues because the 20 is not for pediatrics and the 15 can be given in pediatric age range. So if you're in a clinic that is doing pediatric and adult, it's easier to stock one vaccine, and for logistical reasons, so they actually opted to do the PCV15 as an equal recommendation to the PCV20. That being said, if you get the PCV15, you still have to follow it up with a polysaccharide vaccine if you're immunocompromised at least 8 weeks later. So it's not a one and done with the PCV20. It's much simpler than it was, so if you give an immunocompromised adult PCV20, they're good, they're done. There's nothing else you need to do, but if you give them PCV15, you still have to give them a polysaccharide vaccine. So you still have to stock 2 vaccines. Other strategies that don't necessarily have to do with vaccinating the individual themselves that are immunocompromised is the cocoon strategy. So this is something that was really important early on with COVID as an example, because we knew that people who were immunocompromised were not likely to mount a good immune response, yet they were our most vulnerable in terms of disease, morbidity, and mortality. So what could we do? We could make sure that everyone around them is vaccinated so that the people around them don't get sick, and therefore the person with them doesn't get sick. And so this is a really important strategy when you're taking care of people who are immunocompromised, to talk about getting their family members vaccinated, not for their family members' own health even, just the important, even if they don't want to get vaccinated for themselves because they don't believe they're going to get sick, they need to get vaccinated to keep your immunocompromised patient healthy. This is one of the examples with pertussis vaccine. So that looked at childhood vaccination plus childhood and adolescent vaccination with the cocoon strategy. And basically what I wanted to highlight here is that vaccinating the people, the kids that are high likelihood of getting the disease, and with the cocoon strategy, meaning that, that having that family household layer of protection is goes a long way in terms of preventing disease. And in fact, this is actually seen with other diseases as well, like invasive pneumococcal disease. Once we started childhood vaccination for those things, what we saw is that the grandparents, the elderly people around them, that disease rate actually, the indirect effects were quite high of those vaccine strategies. So really important to look at. And this is sort of a projection, if you look at these strategies, how we can really eradicate some of these diseases. So when we talk to our immunocompromised patients, we ask about who's in the household. Have they got their routine vaccinations to make sure that they have gotten their routine vaccinations? But there are also some other things that you want to make sure of. Want to make sure that they haven't had a live influenza vaccine, although the rates of getting disease from that is quite low, that they don't have that circulating around within 2 months of transplant, or if they're highly immunosuppressed post-transplant, just because of the risk of getting vaccine-derived disease. And then the rotavirus vaccine, if there's a child in the home, that is a live vaccine, and so not handling the diapers of the kid post-vaccine, because that could also be a risk to the immunocompromised adult. So in general, I would say that close contacts can get live vaccines. Live polio we don't give, so I wouldn't give that one, obviously. But in general, you can do it. I would say that this is one of the things that I was mentioning, and then we've had more recent cases, but transmission of imported vaccine-derived polio in an under-vaccinated community in Minnesota. There are people that are getting polio vaccines that are live in other countries, immigrating here, and then their exposure to immunocompromised adults is the risk factor here in this case that was published in 2009, and then we've had this obviously more recent case in New York. Assessing immune response. So for the most part, we don't check titers for people for most vaccines in immunocompetent hosts. That's not something we do because there's been data in clinical trials that suggests that immunocompetent hosts respond well to these vaccines, and there's not really a reason to check. However, some vaccines we do like to check, particularly in immunocompromised hosts, because we are concerned about whether they're really protected or not. And because there could be additional strategies for an alternative vaccine regimen, for instance, that we could do if they haven't responded. For example, in hepatitis B, I mentioned you could actually give Heplisav, or you could give another dose of your standard Hep B vaccination as a strategy if they are non-responder to the traditional vaccine series. Similarly, in Hep A, there's been some outbreaks of hepatitis A that we know in the US, in larger metropolitan cities, and outbreaks in homeless communities. And so because of this recommendation, and because in some communities it's a sexually transmitted disease, there's actually more robust recommendations around checking and hepatitis A serology, particularly in individuals with HIV, to document immune response. One of the criticisms is for doing that is that there's not really a good correlative immunity. So that is a caveat for checking things afterwards. What do we know? What do we think they mean? Are they protective or are they not protected? And that's the argument against COVID vaccine serologies, because they're really variable depending on the lab, and we don't actually know what that correlates with in terms of immune response and decreasing incident disease. As we all know, hopefully everyone's here has been vaccinated, but I'm sure many of you, including myself, have had COVID at one point, and so these vaccines are not 100% in terms of incident disease prevention, but have all obviously benefits in terms of morbidity and mortality from the infections. Some vaccines that we don't typically check immune response, like tetanus and H-flu for solid organ transplants, that's recommended. Varicella, MMR, it can also be checked as well. Meningococcal vaccine, so this is not one that's outside of our routine use is in terms of universal childhood vaccines, and then military personnel, laboratory personnel is not something that we normally give, but there are certain immunocompromised groups that we would give meningococcal vaccine to. Patients who are on eculizumab, and this is not a commonly used medication, but I bring it up because the risk of meningococcal meningitis is 1,000 to 2,000 times higher in patients on this drug, and it's really important that they get vaccinated against both the quadrivalent and meningitis B vaccines at least 2 weeks prior to getting this medication, and repeat vaccination. Despite this, the incident risk of meningococcal meningitis is actually still higher than the general population, and some would advocate using chemoprophylaxis with antibiotics for those individuals. And then HIV is another one where ACIP has a special call-out recommendation for meningococcal vaccine because there are higher rates in people with HIV, although the overall incidence is actually still quite low. The recommendation is to give people with HIV 2 doses 8 weeks apart and then every 5 years. Even aside from the HIV, we have seen reports in MSM of outbreaks of meningococcal meningitis in New York and Los Angeles and other cities that suggest that it is a concern in MSM as a sexually transmitted disease. COVID vaccine, so additional versus booster. So this is a difference in the definition here that I wanted to clarify. So patients who are immunocompromised, they need an additional dose to make up their primary series, as I mentioned. So the primary series would consist of 3 doses. So that's considered a full vaccination. And then they were eligible for 2 boosters early on, even before the 50 and over group were eligible for 2 boosters. And so the number of vaccines that patients who are immunocompromised might have gotten is actually quite high, because if you got transplanted in the meantime, then you kind of have to start over with your primary series. So even if they got fully vaccinated prior to their transplant, imagine with their conditioning and their chemo, their transplant, they probably wiped out all of that, so then they get to start over with their 3 dose. And then of course, everyone should be getting their Omicron, their bivalent boosters anyway. And as we know, immunity wanes over time. It's hard to know when that exact point is for when we say that it's not really working. But as we all know with Omicron, the surge with Omicron, everyone's immunity likely waned versus just not having immunity against that Omicron variant. And this is what I alluded to for the 2-dose series with mRNA vaccine and SOT patients. And so this is just more of that data in particular. And this is looking at antibody titers. And you can see that the titer before the first dose is obviously low, the second dose, and you can see 3rd dose here, that the titers were quite low, and the prevalence of those titers was actually about 40% of individuals before their 3rd dose, but then when they gave the 3rd dose, they went up to about 70%. So this was the rationale for adding that 3rd dose, because less than half of individuals had IgG titers that were sufficient, or felt to be sufficient. And so these are recommendations, but I kind of already went over that. So don't check antibody titers is my main go-to here, main point here. And then if possible, give the vaccines at least 2 weeks prior to immunosuppression. It's not always possible, particularly if someone's getting rituximab. Think about the timing of the rituximab and the vaccine dose, if you could time it optimally before they get their rituximab. And then one other thing is, for immunocompromised hosts, it's important, even if they're vaccinated, they need to keep themselves safe as possible with masking and practicing physical distancing, because we know that their responses are not as good as the general population, and encouraging their family and friends to get vaccinated. So in terms of immunocompromised hosts, there's increased risks of vaccine-preventable diseases. There are different guidance on the ACIP, and then also specific society guidance. So if you're taking care of a large population of transplant individuals, there's specific transplant guidance for immunization, considering the optimal timing and responses that may be blunted. And so looking for other ways that we can prevent, and that could be just behavioral changes like masking and physical distancing, but also encouraging those around you to get vaccinated. And I like the CDC guidance here, but then immunize.org is also another really good resource for patients, or for providers to use in counseling patients. I kind of went through that quickly, so if anyone has questions.
Is there any research in terms of the antibody titers, into variant-specific titers in COVID?
That is a really good question. I don't know if there's actually that specific type of...
And my experience was from December of 20 to July 1st of 21, I didn't have a vaccinated patient catch COVID. Mm-hmm. Then July of 21, we saw Delta. Then we saw, Omicron and these variants come through. And I've had families where, one parent and one kid got Omicron. The rest of the family, we're sharing sodas. We're not doing any precautions inside the home, and no one else gets it, and they were testing. So clearly, where the antibody attaches on the antigen, it can be different from individual to individual. With Delta, part of the antigen changed. Previous antibodies were no longer effective against the new antigen. So,
yeah, no, this is the mystery of it, actually. And I am just reading a book that has not, it's not a medical book, but actually it is about a pandemic, but one of the things is, this is the mystery that we always have with these pandemics and with these surges. Why do certain people get sick? Why do certain people get infected and they don't? What are the differences immunologically? And we don't have those sophisticated tools and testing to really know why that is.
And I've had a couple of patients hospitalized from the vaccine, one in the ICU with myocarditis. I want my patients, if they can benefit, to get the vaccine, but I'm also hesitating in people who should have good immunity based on they had this variant based on when they had COVID and they're vaccinated.
Yeah.
Am I giving them any additional protection if they had Omicron and they were vaccinated against the original COVID? Are they actually going to get additional protection if they still have high antibody titers to both of those variants?
We know from studies from other countries, actually, that antibody titer wanes over time. There's studies from Qatar that show that, and the UK, that show that antibody titers wane, and then the population is at higher risk, and then we get these surges. So I would say that initial response to vaccine doesn't mean that vaccine response is sustained and sufficient. That's what we know from, at least with COVID-19 vaccines. And that could be a mix of waning immunity, but also the emergence of different variants that, that essentially outsmart our vaccines. And it could be that getting these boosters earlier on just was enough of an immune response to overcome that change with the variant, but we just don't know. I think, and what we know now is it's starting to come about more like the influenza. Every year we have to predict influenza, where that's going to be, what antigens, how to tweak the antigens in that vaccine to make sure that people protect it. And we know from influenza, it's not always an excellent match, right? And it's our best, epidemiologic work there that the virologists do to figure out what's happening. And the technology right now and the ability to do these studies and to be real time getting these vaccines out is challenging. And UK came out with their BA.1 vaccine, bivalent vaccine, and when the US, and there's human data with that one, when the US said, okay, but we're already past BA.1, what are we going to do with a BA1 vaccine? We want a BA4, BA5 vaccine. And so that's why we waited like a few weeks, but we also based it on animal data. That's where we're moving forward with this. And that's what we do with flu vaccines. We don't always have human data to guide us, but we know that these vaccines is the same technology. But it's every year, at every surge, we may be seeing something different. Hopefully we're at a cadence where it's every year for these, but we've just not kind of gotten there yet with COVID. But I think your questions are, it would take a lot of sophisticated science that we don't have right now to figure out all of these genotypic, phenotypic differences in people that make them susceptible and what makes them not susceptible. And I think antibody titers, unfortunately, are not the test that tells us that. It definitely isn't with COVID vaccines, at least. I don't know if that answers your question, but yes.
I've got a number of patients in travel that have lived in Vietnam. Have you heard much about the malaria R21 vaccine?
So the malaria vaccine is not approved for travelers. It's approved for kids in endemic areas. So it is not something that is given for travelers at this point. It's for children 5 and less that have a high morbidity mortality from malaria endemic areas. So that's the focus. Yeah.
This might be a little bit of a basic question, and I guess I'm more asking how you would phrase this. When a patient comes in and they're very hesitant about getting the COVID vaccine, and their argument is, I'm young and healthy, I will probably do well if I get, especially Omicron, which I know there are definitely exceptions, but for the most part, they're right. And they say, I've seen all my friends who are vaccinated, they still get COVID, and they can still put vulnerable people at risk. And obviously I'm very pro-vaccine, but how would you articulate your response to that?
Yeah, I think there's a couple of ways depending on the person. One is playing to just their own health, but then it's also community health. So if they're more egocentric, focus on their personal benefits. And we have data, a lot of data now, that people who are vaccinated have significantly less hospitalization rates and death than even with these later surges that people think are more benign than people who are unvaccinated. So I mentioned there was just another study that came out with Omicron that 10 times less likely to be hospitalized if you were vaccinated if compared to unvaccinated individuals with the Omicron surge. So giving them more recent, relevant data, even if it's not something they've personally experienced, this is something we know, that your risk is higher, these vaccines are safe. We have billions of doses that have been given of these vaccines, so even though there may be these few people that have had serious complications, overwhelmingly it's safe. And then I did a talk at jail because there was a lot of vaccine hesitancy, and I actually talk about, well, with whom do you live? Like, do you visit your grandmother? Do you visit, and like plead to that too, to keep their community and their loved ones safe as well. Because their 90-year-old grandmother may not have a good immune response. And what if she gets COVID? And you can prevent that by keeping yourself safe and everybody that goes and visits your grandmother. So I think making more personal related stories, sometimes the talking points of like what's in the news, people don't listen to those talking points. So really individualizing that conversation is really important. People that are vaccine hesitant at this point, they are not going to listen to most of the messaging that's been on the CDC websites or any other, but having those ongoing conversations and connections that are about things that are important to them is a strategy that I've used.
I'll bring up one other, and again, I've been a strong proponent of vaccines, but this myopericarditis in younger people, in young men, it's a 1 in 1,500 risk. A double vaccinated 18-year-old's chance of dying from COVID is 1.25 million or 1.5 million or 1 in a million? Is it worth taking a 1 in 1,500 risk of myopericarditis in an 18-year-old who is vaccinated and has their antibody levels don't drop as fast as an 80-year-old?
Yeah.
How do we target this where it's really needed? Because that myopericarditis risk is real. Usually it gets better, but if the heart's swollen, every once in a while there's going to be a blood clot. Some of the people saying my cousin had a stroke 4 days after their vaccine. Some of those were just coincidental. Some of those probably actually were iatrogenic caused by the vaccine.
Yeah, I think it's really, this is a good point to bring up in terms of the VAERS data, because a lot of people bring that up when they talk about, oh my God, look at all the complications. And I do think there are caveats to looking at that VAERS data when what's reported online as complications, because I think the rates are much higher than what actually is the vaccine, because these are not all validated, and there's a lot of other reasons why people may have strokes. Like you said, they're 60, 70-year-old people with heart disease and lung disease, and these were going to happen anyway. Similarly, I think in young people, there is myocarditis from other viral infections that we know of. Nearly all of those cases are pretty, there were fairly mild cases when we say 1 in 1,500 and managed with just NSAIDs for the majority of those individuals. I'm not saying that there weren't individuals that had severe myocarditis. I think it's still in terms of the overwhelming benefits of the disease spread and yeah.
I'm not talking the first 2 doses because COVID can cause myocarditis too. We don't have a double-blinded, placebo-controlled trial with a 3rd dose in 20-year-olds. Okay, we've got data out of Israel in people over 50 and people over 65 that looks super solid. They didn't send us the data from Israel under the age of 50.
Yeah, I think a lot of this is going to be like a data-free zone, because as we do boosters ongoing, we don't have clinical data for influenza, right? Chloe's my colleague, Dr. Bryson Kahn's my colleague.
Oh, I was just going to add, I think that point about COVID myopericarditis is really important. There was an MMWR report published several months ago now with the primary series breaking down the risk of myopericarditis from the vaccine series and COVID, and the number of people having myopericarditis with COVID way outweighed those from the vaccine, broken down by gender and age. So I found that super reassuring. I haven't seen that with boosters yet, but I
haven't seen it with boosters.
I hope
that's why I limited my question to the booster.
Yeah.
The side effects on the 2nd dose were bigger than the side effects from the 1st. Okay, the sore arm was more common with the 2nd dose by far than the 1st. What are we expecting with the 3rd dose?
Myopericarditis is less frequent with the boosters, luckily. But I haven't seen the comparison of COVID and boosters, and I would love to see that, because I think it would be reassuring.
Yeah, I haven't seen that either. Yeah. And I think we're going to...
No data.
We are going to go with no data in humans, because this is where we are at this point. If we want to, in terms of kind of our booster and our getting to a seasonal type of cadence with influenza, with like influenza.
And if we're evidence-based, how do we make such passionate, strong recommendations? Really have to do.
We do it every year for flu, even before COVID, we were doing it every year for flu. And influenza, the mortality rates are concerning, but not as high as COVID. And I think that's where we are. We're going to be in less and less data zone as we go on. And when we think about these as our routine boosters, maybe co-formulated with influenza, we just don't know yet. Yeah.
Can you discuss a little bit about timing of the vaccine for patients, in particular pediatric patients who has had recent COVID, and how to talk to parents about that, and also before the COVID, that's PCR proven versus parental report positive home antigen test?
So in terms of timing after COVID, in the prior boosters, there was not a recommendation to wait. In the most recent bivalent booster, there is a consideration for waiting 3 months, I believe, after the last episode of COVID to get the booster. If you've had the booster, the last kind of booster, the monovalent booster, to wait 2 months. So there is kind of this discrepancy there. For 12 and over, because the Pfizer bivalent booster is actually only recommended for 12 and over kids, I would say wait at least 3 months to get that, which is what the CDC recommendation is, to get the booster. In terms of home antigen versus PCR testing, they're really now indistinguishable. We're taking, most of the people, many of the people during the Omicron surge never got PCR-based testing. I think we probably dramatically underreported the numbers because most people don't report to public health their home antigen test. So we take that, even for employee health, Chloe works with employee health, and for that purpose, we just take a home antigen test as a positive test.
And in terms of the recommendations, for even a fourth or a second booster shot now, I have a lot of patients coming in asking about that. To Dr. Fletcher's point about the risk of, myocarditis and those things. Is there a specific, population or reason? What are your thoughts in terms of the second booster for non-healthcare?
Oh, the recommendations for this bivalent booster is pretty much everyone get it, right? If they've gotten their primary series, then they should get the bivalent booster if they're 12 and over. For at least the Pfizer one, it's 12 and over.
And if they've had a first booster, there's some people asking about a second booster or fourth shot, the recommendation still be to do the bivalent.
Yeah, and actually the monovalent is no longer recommended as of August 31st when the FDA authorized the bivalent booster. They said stop using the monovalent boosters, so that nobody should be using the monovalent boosters anymore. It is still available for people who need the primary series because it's essentially the same vaccine. So they still have that available for primary series, but nobody should be getting the monovalent boosters anymore. They should just switch to the bivalent booster. Yes.
For people who are just starting the primary series, is there any, or if you can comment on kind of spacing apart the 2 doses? Because I've heard that there's better immune response with doing it 8 weeks.
Yeah, I think there were some data about that. The recommendations are usually with vaccines, any vaccine, when there's a schedule, the timing is really minimal interval. All of the studies looked at it at the 28-day interval for the mRNA vaccine. So that's what we have in terms of what we know works for immune responses from the larger randomized controlled trial. So as close to that as possible. There are some data that suggest maybe stretching it out, you get a better response. That's not necessarily what I recommend for people, but if people are still getting their primary series, I'm just as long as you get the 2 doses, I'm good with that. And there are some, initially there was a recommendation to get it within 42 days, to not wait past that point. They don't have that anymore because they just want people to get it. Yeah. Well, thank you all so much for your time.